Welcome to the CPG webinar for administrators. The focus of today's session is the Episcopal Church Medical Trust's new group Medicare Advantage retiree health plans administered by United Healthcare. This webinar is intended to help you better understand the new retiree plans, policies, and procedures for plan administration. I am pleased to introduce today's presenters. Sean Langenis, who is the today's representative from United Healthcare, Jackie Kornberg, Account Specialist for IBAMS, and John Survey, Senior Vice President for Benefits Policy and Design. Welcome, Sean, Jackie, and John. It is our sincere hope that the information provided to you in this session will assist you in your work as employee benefits administrators. Now I believe I am handing it over to you, John.
All right, thanks, Bob, and good afternoon, everybody, and Jackie and Sean. Good to see you guys again. So if you flip to the next page, Bob, that'd be great. But today I'm excited to introduce what we're doing in the retiree medical space. Over the last many years, we haven't had any changes, and it'd be a relatively sort of standard year. But this year, for 2022, we're introducing a new solution for our retiree medical side. So what I'm going to do, today's agenda is to tell you what's new for 22, and I'm really excited about it because we believe we're going to provide a better benefit at a significantly lower cost for our retirees, both on the benefits side as well as the subsidies contribution side. And then we're going to go into a little more details of what the plans look like, and includes the medical components, the RX, as well as the ancillary coverage, which many are not changing. Then I'm going to hand over to our United Healthcare, Sean, and he's going to go through a lot of the details of the product, the Group Medicare Advantage space. And he's going to go through a lot of features which are in there, and not everything, but enough to show you what's going to be in there, give you a good sense of the value the program brings. And then we're going to go into the communications support to help the transition. And then before we go into questions and answers, Jackie's going to take us through the enrollment process to understand the timing and when that all occurs. So that's our agenda. It's pretty packed for an hour. So we'll try to get through things relatively quickly, and of course we'll leave enough room for questions and answers at the end. Next page, please. So what's new? We are replacing our current Medicare supplemental plan with a United Healthcare Group Medicare Advantage plan, which is PPO offering, a national solution. And we really did a lot of research on this over the last couple of years, and we really fully convinced to believe that this is the best way for us to provide retiree healthcare coverage going forward. The main reason is it's a improved delivery system, but it actually is proven studies that shows that Group Medicare Advantage improve the outcomes of our retirees far better than a Medicare supplemental plan, which we have today. There's going to be savings to both retirees and CPF, but retirees are going to see significant more than that savings in the premiums, but also in the designs. The designs are enhanced over what we have today. The positive news, we are staying with United Healthcare. We went through a very rigorous RFP process, and they're our current med sub carrier, but after a very diligent process, we believe they had the best solution in this product range. And we're just excited to stay with United Healthcare because they've been a good partner for over the last multiple years. There are some additional benefits I want to tell you about, which includes home healthcare visits, transportation benefits, wellness benefits, concierge, house calls. So there's a lot of extra benefits which are in the plan, the new plan, which are not in the current plan, which our retirees should be excited about. And really, we are a slow follower in this. The market's moving there. Most of the market, well over 50% of the market is in for retirees, both in the individual side and group side, are in a Medicare Advantage space. So we're not fast adopters, we are slow followers, so we are actually catching up to the broader market. Next slide, please. So this gives you an idea of what we looked at. There's sort of three main products out in the industry. On the left side is our current Med Sup plan, which we offer today for many, many years. All the way to the right are the individual Medicare Advantage plans, which you see every fall advertised, and they're local plans, mostly HMO type programs with limited networks. And they have a lot of advantages, but the disadvantage is they're not a national solution, and they're individual contracts from the participant to right to the insurance carrier. We didn't think that's what was right for our population, but on the group Medicare Advantage, which is the middle column, it's really the best of both worlds. It's a group contract which we own and control and work with United Healthcare to customize design for our population. It's a national solution in all 50 states and all U.S. territories, and it really accepts all Medicare providers are in part of it. It's not just a network plan, but it's all Medicare providers. And the main reason, some of the other key advantages is the integrated plan where there's no more coordination with Medicare. United Healthcare is the point for both medical and drugs. So it's a simpler experience for our retirees. And it just has better care coordination and support to retirees to produce better outcomes for our retirees. So that's why I went to the middle column of the group Medicare Advantage space, because it really is the best of both worlds. Next slide, please. All right, so now I'm going to go quickly into high level of the designs. So the eligibility rules, I'm not going to go bullet by bullet, but generally it's the same eligibility rules that we have today. You have to be enrolled in both Part A and Part B. That's a requirement to be in our Med Sup plan. And the 5 years accredited service for clergy and their eligible dependents, and the same 5 years for lay. You can see the details on the slide there. But we're not changing the rules to be in the plan. The key thing is you have to be enrolled in both Medicare Part A and Part B. Next slide, please. All right, so this is a very, very high level, just to show you the cost and the two main provisions in the plan. As you can see, the premiums overall, you see there's two plans going forward. There's going to be a comprehensive plan, which is an enhanced version of our current comprehensive plan, and a premium plan, which is an enhanced version of a current premium plan. We're getting rid of the plus plan. That sort of created a sort of unnecessary choice. And we're also decided not to offer our medical only plan. So this is both medical and drugs in the plans. And the reason why, the main two reasons why we did that is there's significant cost savings for these new programs. As you can see, the comprehensive plan on the page for the new GMA is $196. The current cost of this Med Sup plan is $400 and would probably be higher than that for 2022. We have over a 50% savings for both plans. And with that cost savings, and although there's a concern that you can only have one Medicare Advantage plan, either medical and or RX, we decided not to take that risk. We decided to really only offer medical and RX. If they want to, don't want like that option, they might have to go someplace else. But with the cost savings, we really feel it's a very competitive offer, just to offer two, and to avoid any too much choice for retirees. So the key design provisions, neither plan's got a deductible. Currently in the comprehensive plan, there is a deductible, so that's an enhancement there. And the out-of-pocket maxims are consistent with what they are today, but you'll see in future correspondence and in future slides, which Sean's going to take us through, a lot of the cost sharing is lower through copays and so forth in our current plans as well. One other note, the Kaiser plans we offer today in some locations will be maintained in the current structure. There'll be no changes to those options. Next slide, please. All right, so it's not just a group Medicare Advantage plan with United. So I just want to show you that we're offering basically all the similar support provisions in the plan, but they're going to be in a couple of different buckets, right? Underneath the UHC group Medicare Advantage plan, it's going to include the medical, prescription drugs, hearing aids, the Renew Active, which is replacing silver sneakers, and the Global Assistance Plan. That'll all be through United Healthcare's program. The other benefits that you should typically tie to a retiree plan is IMED will stay with Vision will stay with IMED. The EAP will continue to be with Cigna Behavioral Health. We'll continue to offer health advocate services, which will probably be less needed, but still be available to our retirees. And the dental plan, which is additional premium, will be able offered through Cigna. So the same scope of benefits, they're just going to be set in a couple different buckets, but overall the same program across ancillary coverages. Next slide, please. All right, so this slide shows you the subsidy component, all right? So this is where we're not changing how the subsidy is calculated between retirees that who were eligible to retire prior to July 1st, 2013. At 20 years of accredited service, they get the full subsidy. 19 to 10 years of service, it drops $2 per year of credit service to 20 years. So at 10 years of accredited service, you have a $20 reduction in your subsidy, and there's no subsidy between 5 and 9 years of service. For retirees that were eligible to retire after July 1st, 2013, same formula, it's just that the percentage reduction for each year after 20 years of service. So that's not changed. It's the same methodology we've done in prior years. The changes here is the subsidy is now going to be set at the premium level. So currently we set it at the comprehensive level for the Med Sub plan. Going forward, it's going to be set at the premium plan, which is a higher subsidy target in sense of value. So the new subsidy will be set at $286 per month at 20 years of service. So now what that does, it allows you to buy the premium plan at no cost. And if you decide to go to the comprehensive plan, it frees up subsidy dollars for to purchase dental. So generally, the rates went down by 50%. The subsidy went down less than 30%. The result, we actually increased the value of the subsidy of what you can buy for that subsidy going forward. So that's what a lot of the savings to the retirees is going to come. In the next few slides, you'll see how that works out. And then on the right side, you can see how the scale works for people who retire less than or eligible to retire after 2013. Next slide, please. So here's the illustration to show you how it works underneath the new subsidy structure. So as I indicated, the subsidy is now based on the GMA premium plan. So the premium is $280. As you look to the far right, the premium is $286. The subsidy is $286. So now the cost of the most valuable plan is $0. It doesn't cost the retiree anything. In today's day, for the Med Sub plan, that would be a $205 increase to the retiree out of the pension plan, of the pension benefit. They can still buy dental. The cost of dental will be the same as it is today, so they're still paying $90, but overall they'll be saving over $200 a month if compared to the premium plan underneath the Med Sub. Now you move to the left a little bit. You decide, oh, you know what, I don't really need the premium plan. I'm fine with the comprehensive design, which is still very generous. That premium is $196. The subsidy you're receiving is still the same $286 at 20 years of accredited service. I have now $90 extra to buy dental. So at $286, so if I go the comprehensive plan, I can get medical for no cost and dental at no cost. That's for a single individual. So overall, I significantly reduced my savings for a retiree. I basically get both coverages for free or no cost. So a significant improvement in the cost structure for retirees. Next slide, please. This illustration is for someone who is eligible to retire after July 1st, 2013. So they don't have a full subsidy. So again, start on the right-hand side, all the way to the right to the premium plan. So their cost, the premium rate's the same $286. The subsidy is $143 because it's 50% of the $286. The remaining cost would be to pay for the premium plan would be $143. Again, that would be well over $200 more than they're paying today. It's $143 is $200 less than they would be paying today. And then there's to buy dental, and then you can see additional cost sharing to add the dental to that coverage. Now, if you could look at the comprehensive plan, where most of the individuals are who have this 10 years of accredited service, the premium is $196. The subsidy is $143. Their cost is $53. I know there's still a little additional cost there, but today their cost would be for the Med Sub plan would be $200 a month. That's nearly $150 a month savings to that retiree. And then you can see how the dental cost adds on to it. So even though there's still cost sharing underneath the scenario, their cost is significantly reduced from what they had today, what they would have today in 2021. So in every single scenario, the retirees has a lower cost out of the pension check underneath the group Medicare Advantage space plan. Next slide, please. So now I'm going to hand it over to Jackie. So she's going to get some additional information, additional benefits before we hand it over to United Healthcare. Jackie?
Thank you, John. So as John discussed options above, he did mention that dental would have an additional cost. It is an option for groups to purchase dental through the medical trust. And we can talk about how to enroll in dental for those who are not currently enrolled. But for those who, next slide, please, Bob. Thanks. So for those who are currently enrolled, you can find a network provider using their app. You can call Cigna. You can also go online to Cigna.com and you can find a provider and also see your benefits that way. And then next slide, please. So the dental plans that we will continue to offer, there are 3 different plans available to you. All of them provide 3 preventative visits annually, regardless of which plan you select. So the 3 plans are preventative, basic, and dental and orthodontia. Members can enroll and change their plans during annual enrollment. This year, because we are rolling out the group Medicare Advantage plan, if a retiree enters onto the website, which we'll talk about the websites in a little bit, they'll be able to go in and they'll see if they already have the dental selected currently as one of their that they're enrolled in. They'll see that it will be selected when they go into annual enrollment this year. If they don't have it and they want to enroll, they can go online and enroll this upcoming year. And we do have instructions on how to do that, which I'll talk about later as well. Next slide, please, Bob. Thank you. Many of you may be familiar with these additional benefits because they are offered to our active members. As John mentioned, these are going to be included for all of those who are enrolled in our GMA benefits or Group Medicare Advantage. So these benefits are provided at no additional cost. And we have iMed, which does provide an annual eye exam every year. We have our Cigna Employee Assistance Program, which offers many benefits and services to members and to their household. Examples of these services, if you'd like to see, there's a brochure called 100 Reasons to Contact the Employee Assistance Program, and you can find those brochures on cpg.org/MTDocs. If you'd like to go and check those out and provide those to members as a resource, they're very good to have. And then we also have the Health Advocate, who helps in finding and scheduling appointments with your providers. They help you get to the right provider, and they help resolving insurance claims. They can help answering questions about medication and treatments, and they can help with transferring medical records if you need assistance with that. And then I'll go ahead and the next slide, please, Bob, and I'll turn it over to Sean to share with you benefits offered to our retirees through the United Healthcare. Thank you.
Thank you so much, Jackie. And Bob, we could head to the first United Healthcare slide, the next slide in the deck. As John mentioned at the beginning, of the presentation, United Healthcare has been a very proud partner of the Episcopal Church Medical Trust and CPG as partners and as account management team partners for nearly a decade at this point. And so we're very proud to be able to work with the Episcopal Church Medical Trust and its retirees to bring what we think is a very exciting new benefit to those retirees beginning in January of 2022. And Bob, if you could move to the next slide, please. So not to bore anyone to tears with what is almost exactly 60 years or is coming up on 60 years of Medicare benefits for retirees in the United States, and certainly not to insult anyone's intelligence about how Medicare works and how Medicare Advantage plans work. We did think it beneficial to maybe start with a common footing for everyone to talk about how Medicare works and how Medicare Advantage plans work quickly before we talk a little bit more about the details of the ECMT plans. Medicare, as a review for many of us, is a federally funded medical insurance program for retirees who reside here in the United States or have lived for consecutive years in the United States. They were not citizens. Most folks will become eligible for Medicare when they turn 65 years old. Some folks will become eligible for Medicare before they turn 65 by reason of something like long-term disability or having end-stage renal disease or ALS, also known as Lou Gehrig's disease, are automatic qualifiers for individuals before the age of 65. But for most of us, we will become eligible for Medicare benefits when we turn 65. Medicare, like a lot of things, is not necessarily free. It is a fantastic benefit for retirees, but it is not free from the federal government. We all pay for it either by our payroll taxes. You're familiar with that line item in your pay stub, and as it comes off year over year as you're doing your taxes, as that line item that's in there. For some elements of Medicare, there's also a premium associated with it. We often call the Medicare configuration, as we're briefing it, the ABCs of Medicare, and that's because Medicare was very neatly designed and aligned with different parts with alphabet names, so we could all keep it straight. The very first and oldest piece of Medicare was Part A. Part A helps pay for our hospital stays. The second piece, which came into being not long after that first hospital stays piece, is Part B, as the alphabet goes, and that helps us with our office visits and those things outside of the inpatient and hospital setting that Part A does not pay for. And the way Medicare works is all those payroll taxes and funding that comes from the federal government go. And to oversimplify just a little bit, Medicare will pay for 80% of specifically Medicare covered services, a phone book long listing of things that are covered by Medicare. Sometimes it's a little bit easier to describe things that are not covered by Medicare, and a good example of that would be elective surgeries, something like a facelift or a tummy tuck, something that isn't exactly needed, would not be covered by Medicare. But for all that phone book worth of material that is covered, Medicare will cover 80% of that. So for those of us who weren't necessarily math majors, if Medicare is covering 80%, that leaves 20% to be covered by somebody else. If you do not have any kind of alternate insurance, that somebody else is the retiree themselves. Medicare will get that first bill and pay their 80%, and that leaves, again, that 20% to go to somebody else. Most retirees decide that they need some additional form of insurance to help with that additional 20%. And previously, ECMT retirees were using a supplement plan. Medicare supplement plans are, I think, an appropriately named form of insurance because it does exactly what it says it does. It supplements Medicare. Medicare pays that 80% on that first round of the bill, and then the second time around, the bill actually goes to a supplement insurance company for them to pay whatever the portion of, and there are different styles of those plans, but whatever the portion of that remaining 20% the insurance plan is designed to cover. Group Medicare Advantage, the topic that we're here to discuss, works a little bit differently. And to continue with our alphabet soup, Medicare Advantage specifically is called Part C, and that came around a little bit later in the 1980s during the Reagan administration. And what Part C in Medicare Advantage is it takes those Part A and Part B, or sometimes called original Medicare benefits, repackages the way the government finances those, and hands those benefits to a private health insurer like United Healthcare, and has the private health insurance company administer those benefits. So I talked about that two-phase billing a second ago, where the first phase goes to CMS or to the federal government for them to pay for. And then the second portion of the bill goes to an insurance company for them to pick up. Medicare Advantage works differently in that entire bill, 100% comes entirely to that private insurance company, again, United Healthcare in this case, for adjudication and for payment. So we'll talk a little bit about the benefits of Medicare Advantage, why it works a little bit better, why it is more cost effective, and that streamlined experience is one of those reasons. That single point of adjudication is one of the reasons that there is additional savings to be had in the Medicare Advantage world that we are not seeing as much of in Medicare supplement plans over the last several years. Our group Medicare Advantage plan is different still than what we see in individual Medicare Advantage plans. If you're watching TV, and especially during the fall, that daytime TV tends to have a lot of commercials for individual Medicare Advantage plans. And very often those plans, it's an individual plan, anyone can call in and enroll into those, and very often you'll see, and they'll advertise on TV, that they have very, very inexpensive premiums. Sometimes we'll add in additional benefits. But what we're able to do in the group Medicare Advantage world that you do not see in the individual Medicare Advantage space is a couple things. First of all, we were able to, in group Medicare Advantage, we were able to design a plan specifically that works for ECMT retirees here. In the individual Medicare plan, you're able to get and buy what is available in your area. That can be very different for an ECMT retiree in Los Angeles, Portland, Oregon, Newark, New Jersey. It can be very different for any one of those retirees. But in a group Medicare Advantage setting, we're able to, as John suggested earlier, design a plan that is familiar to, works very similarly to what those retirees were used to dealing with previously. So they have that similar experience, that similar value proposition for those retirees. Very often in the individual Medicare Advantage plans, you'll see those are HMO plans and are usually constrained to a very tight network in and around that area where the retiree resides. But in group Medicare Advantage, as John alluded to earlier, this plan we're able to design not only to have a broad coast-to-coast network within the United Healthcare family, but in this case to also have the exact same out-of-network benefits for retirees who go to an out-of-network provider. So that same copay, whether your provider is in the United Healthcare network or outside of the United Healthcare network, as long as John said a second ago, as long as they accept Medicare in the first place, and as long as they agree to work with us as a group, United Healthcare, as a group Medicare Advantage plan. So again, even though they are not in our network, the retiree can still go there, again, as long as they accept Medicare in the first place and as long as they agree to work with United Healthcare. As the slide suggests in front of us, that gives that near universal provider access. Again, all those groups, provider groups and facilities that are in our network from coast to coast throughout the United States. It gives that same benefit design that's comfortable to the retirees and approximates their experience before and what they've seen before. John talked about the improved financials and the flow of the marketplace in this direction. Streamlining of the experience for the retirees. Our last stop in the alphabet soup of Medicare Advantage would be Part D, what we often call on the commercial side of things, the RX plan, or the prescription drug side of things in the Medicare world is called Part D. That also is incorporated into our Medicare Advantage plan for the ECMT retirees. So we'll actually see a picture of what our retirees card will look like in a little bit, but it's that same single card whenever they go to the provider, whenever they go to their pharmacy, if they have to go to the hospital for some sort of inpatient stay, it's that same single card. It's not their Medicare card. And on the back, it's that same number that they have to call whether they have a question about any and all of those healthcare needs of theirs. And lastly, on the Part C and the Medicare Advantage side, and we'll get a little bit deeper into this in a couple of slides, we were able to, on top of those original Medicare benefits at Part A and Part B, those coverages that we talked about a second ago, add additional coverage types and programs, all designed to know more about the retirees and to help us help them live a healthier life. And that is obviously our end goal for those retirees. Next slide, please, Bob. Thank you. So some of this is by way of review. We just talked about it a minute ago, but our plan provides coverage for visiting doctors, clinics, and hospitals on a national PPO basis. It's a PPO, again, it does not require any kind of referral out to go see a specialist. A retiree can certainly go and choose to do that. It does not need to go back to some sort of referring doctor or primary care physician in order to do that. And again, national basis, those we talked about, I think it was Los Angeles, Portland, Newark retirees. We have providers in all of those areas for those in-network benefits. And as I mentioned a second ago, also out-of-network benefits and the ability to see retirees, even if they are outside the ability to see providers, even if they are outside of our network. A lot of questions that we get from retirees as they understand how the network works, but they want to know about their specific doctor. Is my doctor in network? Is a question that we will frequently get, and there are two great ways to find that out. We'll talk a little bit more about our website as being a great resource for retirees, not just for provider questions, but for a lot of things. And you'll see it listed there as uhcretiree.com/ECMT. On that website, retirees will be able to find, search for their doctor and doctors in their area. I will say that the website lists network providers. It does not mention it does not list out providers who have accepted and that we've worked with in the past as non-network providers. But we'll talk a little bit in a few minutes about our call center, and retirees will be able to look for that provider information online to find those in-network providers. But they'll be able to call in to our call center and find out both in and out of network providers, as well as much more if they have the opportunity and the time to take that in. I recommend, by the way, whether a retiree has a specific question or not, if you're dealing with one in the future, I recommend as we get closer and closer for all retirees to sit down and bring a list of their providers, maybe their conditions, any prescription drugs that they're taking, to sit down with one of our call center advocates and just have a discussion so we can make sure that this plan is going to work best for them. Next slide, please, Bob. Our Part D prescription drug plan, we say that first bullet there has thousands of national, regional, local chains and independent neighborhood pharmacies in our network and in their area. At last count, we say thousands here. I believe the last time we had an official number, it was some 65,000+. The number was going up faster than we were putting out slides, so we just went to thousands. So don't let that number thousands scare you if you see it listed there. It is tens of thousands. And again, that last count, over 65,000 pharmacies, again, national, regional, local chains, and independent neighborhood pharmacies. Thousands of covered brand name and generic prescription drugs. Again, a program within the Medicare Advantage prescription drug plan that was specifically designed for ECMT retirees, not something that they were buying out a street plan, trying to figure out what the best plan would be available for them, trying to match their historical experience and making sure that the new plan will have as approximate an experience for the retirees as what they have seen previously, including a bonus drug coverage, in addition to just what the Medicare Advantage and Part D drug coverage provides. Next slide, please, Bob. I talked about the additionals and extra stuff on top of what Medicare asks us to provide, those original Medicare benefits, Part A and Part B. We are allowed and we are advocates of additional programs on top of that. Again, all with that goal of getting retirees to live a healthier life, knowing that one of the very best things we can do, not just with healthcare, but with really any of our insurance, is to pay those premiums and then do whatever it is we need to do to not have to use the insurance. Some of that is inevitable, some of that is outside of our control, but certainly for healthcare, so much of it is in our control. We want to give the retirees the tools to be able to do their very, very best that they can to take control of that. None of these programs are mandatory. They're all certainly encouraged. Some of them are rewarded. We'll talk a little bit about rewards in a few slides. But again, to encourage with the carrot rather than the stick, retirees to go out and take those additional benefits. One of which is an annual physical and wellness visit. So Medicare itself will only pay for one annual physical. Your very first annual physical, often called your Welcome to Medicare physical, when you are very first eligible for Medicare, again, after age 65 for most of us. But we have found that it is a great step and that we want those retirees to get a physical every year if they can. So for us, that is an annual physical and wellness visit. We want those retirees doing that, so we will encourage and reward retirees to do that in a timely basis every year. Virtual doctor and virtual behavioral and health visits. This has been a topic of much conversation over the last year or year and a half about encouraging retirees to not necessarily use that office setting and to be able to call in and have additional avenues to get care when they need it, to include virtual care. I have been able to use virtual doctors before in my life. There are certainly times I've used our programs that are available here in United Healthcare, and there are absolutely times, I think about the flu is actually, this is pre-COVID fortunately, but the flu is one time I could not get to my doctor. I couldn't get anywhere, but knowing that we had a virtual doctor available to us through United Healthcare was an outstanding resource and a big help when I was not getting out the door, that's for sure. House calls is a program we will highly encourage with all of our retirees. I always think of house calls, I always think back to the TV show Little House on the Prairie as being an antiquated notion of when you did not go to the doctor, but the doctor came to see you, perhaps with that leather bag that I don't even know if they have those anymore, but hopefully that's something. I'm not the only one who remembers Little House on the Prairie, and I'm not dating myself too terribly. But House Calls is a program that we put together, hearkening back to that time, where we actually have nurse practitioners who work for United Healthcare who will go to a retiree's home, again, not mandatory, go to a retiree's home on an annual basis, sit down and just talk to them about their care and talk about their healthcare situations, and just try to help them. Look at their medications that they're taking, make sure none are contraindicated. Look around the house to make sure there are no slip and fall hazards. Again, all at the welcome of the retiree, nothing forced. To take blood pressure. This is not meant to replace a physical or any type of visit to their physician or to any other kind of specialist, but meant to supplement that, just so we can know a little bit more about them and we can help them in that process. The last few things, or these next two bullets, I should say, I'll go through quickly, but post-discharge services, Medicare over the last few years has allowed us to add additional, even more services on top to take those dollars that Medicare provides us and to turn around and give those even more as benefits to the retirees. And in this case, it's the comfort of having meals and transportation for if you've been in the hospital. We know it's not always the easiest thing to get certainly nutritious food brought to your house, or to get that transportation to that follow-up visit if maybe you're in no condition to drive post-hospital stay. But the plan will do that, and there's some details about the circumstances under which and how many meals, et cetera. But again, trying to bring that value to those retirees to help them out in that post-discharge service area. We know that if we can provide even little things like meals and transportation, the chances of them needing to go back into the hospital actually reduce significantly. The last program I'll talk about here is the last bullet, but Renew and Renew Active by United Healthcare. And both of these are programs designed to get retirees to live that healthier life. Renew is great at providing things like recipes and brain games and additional resources or things available in their area to get them thinking about their health and to get them more active actively involved in their health, and again, in their health, and again, to give them some of those resources and tools to be able to do that and make those good decisions. Renew Active is one of the things available under that umbrella, and it specifically is a gym membership to get those retirees out and working out, and again, trying to get them to live that healthier life. Next slide, please, Bob, and I think we'll go through these relatively quickly. John mentioned the out-of-pocket maximums and the two plans. There is a listing included here of the differing co-pays between the two plans as a comparison. I won't read down through them individually, so Bob, if you could just go to the next slide, and then the next slide again. But all of these are available in here. And perhaps more importantly, all of these will be sent as we get closer and closer to open enrollment. All of this detail plus way, way more detail about how the plan works sent out to the retirees to give them the tools, again, to sit down, make that decision, and utilize our support resources to help them with that. Bob, next slide, please. United Healthcare Hearing is another benefit that we have put under this plan, and one about which we're very excited over the last few years about United Healthcare Hearing and becoming more directly involved in this space. It is an in-network only benefit, but in that network, it does provide over 7,000 nationwide locations, which was 99% network adequacy, meaning within just a few miles of each one of ECMT's retirees is one of these locations, wherein they can get the hearing aid that they need. Unfortunately, the hearing aid space had gotten a little bit out of control as far as what was available, where it was available, and lastly, how much it was costing individual retirees out of their pockets. But with United Healthcare Hearing, not just for ECMT, but for many, many of our retiree groups, we've been able to collect and to try to control that environment, control the cost, and provide overall a more beneficial experience to the retirees to get them the hearing aids that they need. Bob, next slide. I spoke about Renew Active a second ago and being that gym membership. Bob, I think we can go to the next. As well as Renew, there's those brain games and Renew Online. Bob, next slide, please. Lastly, United Healthcare Global Assistance, and this is a place where we have tried to, again, approximate that experience that retirees, ECMT retirees have had previously. Medicare, as generous as that program is, Medicare for the most part stops at the water's edge and does not follow us overseas unless we have an urgent or emergency need while traveling overseas. But what United Healthcare Global Assistance does is provide extra on top of what Medicare would do, but emergency medical evacuation services, other types of travel and health information, as well as a wealth of other services to help those retirees as they're getting ready to head overseas, so they could understand potential needs and healthcare needs and what type of emergency services would be available for them before they are on their trip. Next slide, please, Bob. And I will turn it back over to Jackie and give you all a break from listening to my voice.
Thank you, Sean. And Sean will be right back. If you'll go to the next slide, we're going to go ahead and take a look at some key dates to pay attention to as we start to roll out the group Medicare Advantage plans. So Sean kind of mentioned that there's ways to find the plans and ways to find providers, and he's going to talk a lot more about that in the next couple slides after I'm done with this one. What we wanted to do in our approach for this is really to talk to our administrators and to our diocesan leadership, our chaplains to the retired bishops, and kind of let you guys know this is all coming out. We want you to know the time frame that you can expect to see information delivered to our retirees, so that if questions start to come your way, you know what's coming to you. So some of these things to know about is, for example, today's training. This webinar is really to educate you, to let you know what's coming your way and to our retirees. But then one of the things that you're going to notice as we go throughout this is when the websites will be available, when the call centers for our retirees will be available, and things like that. So let's kind of go through these dates together. As we mentioned, we're beginning trainings now with our diocesan leadership to let you know what's coming before it actually comes. We're also going to be sending out an announcement letter to the retirees, which will go out on July 30th. And this is going to all enrolled retirees, letting them know what the changes are, what the timing will be, where they can find resources for this enrollment process, and where they can find information about plans and benefits. This letter will go out in the mail. However, we do plan to send to all diocesan leadership, such as yourselves, and to our bishops and our chaplains, letting you know that this has been sent. We'll include a link of what the letter looks like that will go out on the ARC, our Administrator Resource Center, so you can go and see what we actually sent, and you'll have a copy for yourself to refer to. And then we will also make the UHC website and call center will actually not be available until August 4th. We're kind of letting you know this is coming before it actually becomes available for members to go and look at it. Once that becomes available, it will include it will be a customized website. It will outline our plan details. Sean's going to talk about that a little bit more. And then we're going to begin in August through October. We're going to start having our virtual member education sessions, and we're going to start meeting with members, letting them know what the benefits are, answering questions, informing them, really provide member education for these retirees so that they know what they're getting into and what's available for them, and answering those questions as they come along. And we'll also be providing educational brochures and flyers that will be available on the website at uhcretiree.com. Then we're going to begin our annual enrollment process. So we'll begin sending our annual enrollment materials. Those will be mailed out the week of September 27th. Then annual enrollment will actually open up from October 15th through November 12th. After annual enrollment closes, UHC will then send out the new ID cards. Everyone will get a new ID card. This is a new benefit. And then they can begin using our benefits effective January 1st, 2022. Sean is going to talk about, once those all go out, once everyone's enrolled, he's going to talk more about what support is available and communications are available. So I will turn this over back to Sean again. Next slide,
Thank you, Jackie. And thank you for providing everyone a little bit of a break from listening to me drone on and on. So thank you for that. Some of this will be by way of review because we did touch on it above, but it's all important. So I do want to make sure that that we get to it again. I mentioned our UHC advocate and online support. And advocate specifically means what's available via our toll-free number, as well as our custom greeting. These are call center folks who have spent years now focusing on retiree questions. Actually, I will call center individuals and points of contact there with questions quite frequently because they are truly subject matter experts and know exactly how the plan is going to work for those retirees. The number, which is posted here, and I won't read off to you, but it is available from 8 a.m. to 8 p.m. Eastern Standard Time, Monday through Friday. And I would recommend for all retirees, whether they have a specific question or not, to call in and spend some time with one of our advisors. Our advisors, it's always interesting to think about from a call center perspective. They are not evaluated on how quickly they turn around a phone call, meaning they can have a longer and meaningful conversation to get to know that retiree, to understand the things they're dealing with, and again, lastly, to make sure that this plan is working best for them. The average call for one of these, if you were curious, is about 24 or 25 minutes as an average as retirees sit down to talk about how the plan would work for them. If you're speaking to a retiree and you're recommending that they call in, it oftentimes goes best and most efficiently on the call if they have that list of, again, doctors that they see or have seen, a list of their prescription drugs that they take or have taken, again, to see where all of those fit in with our plan, in network, out of network, and accepting otherwise, as well as their medications and where they fit in on our formulary tier. Again, that call center and that advisor I highly recommend, and I think is the very best way for any retiree to sit down to understand their plan, both for making a decision that they are asked to make or are able to make this fall, as well as when we get into the new year to help them understand their plan, and again, getting them to use that health care that they need. The website goes live on August 4th. And again, that's www.uhcretiree.com/ECMT. That'll have a few things, those in-network provider listings and searches that I mentioned a second ago, but even more on plan benefits, how they work, as well as something that we're pretty fond of, the Virtual Education Center, or VEC, which is an education environment for retirees to learn more about Medicare, like we talked about back at the very beginning of our time together today, to help them understand how Medicare works, and then more specifically how the ECMT plan works. It is a site that is dedicated, the ECMT site /ECMT site, dedicated to that group. Although a lot of the information is universal across all retirees, it'll have other plan information specific just to the ECMT retirees. A great resource, not just to learn about it now, but going forward for those retirees when we go live in January of 2022. Next slide, please, Bob. For retirees, what to expect after they enroll this fall. Right around the time of the holidays and heading into and toward New Year's, retirees can expect to receive a quick start guide, which is exactly what it sounds like. It is several sheets of paper which will help them on those very first things that they'll want to know to get their plan rolling in the new year. As well as it'll have that member ID card, which is what they'll need. I promised you a picture of the member ID card. I will show you it on the next slide, which is what they need and what they will bring to, again, not just their pharmacies, but anytime they're receiving care. That member ID card will then allow them to go in, and they can log on and even have a more specific experience on the website, be able to see things like their claims and plan information come through when they start having claims come through. And then soon after the effective date, in January, February, sometimes into March, depending on how long it's taking us to get everybody on the phone. But we will call in just to check and see how the retirees are doing. And again, what can we help them with, understanding their plan, getting them to use their plan as it is brand new to them and heading into the new year. Next slide, Bob. Thank you. I promised it. And this is a fulfillment of my promise, but down in the lower right-hand side is that United Healthcare card, and pretty darn close to what it'll look like, including the ECMT logos below. And again, retirees will need that for all of their healthcare needs. Sometimes as we get a little bit closer to the year, we will get 1 or 2 phone calls about retirees who have not received their new card. They're getting a little bit nervous. That's okay. The card is it's a piece of plastic. If a retiree does not have it and you hear about it, but they want that card, or maybe we're even into the new year, they're going to see their doctor, it's stuck in the mail, or they haven't seen it come through quite yet, just let us know. Again, that the card itself is a piece of plastic, but that member ID and knowing that we are working with them is what's most important. We were more than happy to reach out to a provider to get them any kind of information they need about the new plan, and can even get a new card sent out to a retiree if they've already lost it or whatever the case may be. Previously, retirees have had to use their red, white, and blue Medicare card. Still an important thing to have, but in this case, they don't need to bring it around with them wherever they are heading. They certainly don't need it for their healthcare needs, as they'll only need that United Healthcare card. They can put that in a safe place where they store their other important documents. Next slide, please, Bob. The website we've spoken about quite a bit, and we've talked about everything they can look up now to help them think about the new plan getting ready, and all the additional benefits and information that'll be available for them come January after they enroll with their card. Next slide, please, Bob.
Thank you, Sean. So the next couple slides, we're going to go over annual enrollment really quick, and then we'll make sure to have time for questions and answers. Next slide, please, Bob. So after members receive their packets in the mail, they'll go online to annualenrollment.cpg.org, and they can review their options, choose the plan that they want, and they can also consider, if they're not in already, a dental plan if they want to sign up for one. And then administrators. So this year for administrators, we do have a website available to our administrators that will provide information not only on retirees, which is what we're talking about today, but it'll also include information for your actives. So it's all going to be in one place with links to where you need to go to find information for both, in case you get questions from, I know you're going to get questions from our actives, but you're probably going to get some questions for our retirees, because this is a year of transition for them. So if you go to cpg.org/AE-admin, this is just live today, and it is available for all of you to get resources that you need right at your fingertips. And then for additional help enrolling for our members, if they need additional help or have questions, of course, Medical Trust is here to answer their questions. They can call us. If they choose to take no action, what happens if they do nothing? They want to do a passive enrollment this year. If members do nothing this year, by November 12th, if they've done nothing, they will automatically be enrolled in the GMA premium plan. So they will be enrolled into, not the comprehensive, but the premium. And they will be enrolled in the same dental plan that they have currently if they're already enrolled in one. So that's something to consider in case they want to go down to the comprehensive plan and then purchase some dental. There will be options available to them. We do highly recommend checking out our website for annual enrollment this year and paying attention to all the information that will be mailed out to our members, and you'll have the opportunity to view that as well. And then next slide, please, Bob. And I can see we have some questions in the chat log, and then we are here to answer questions that all of you have. So I'll turn it over to Bob.
Thank you, Jackie. I want to thank Sean and John also for the information you've presented to us. We're now going to enter into questions and answers and discussions. And just to briefly go through, if you have an answer you want to ask, you can submit it in the questions window of the GoToWebinar control panel. We will answer those questions in the order they come in, and if we run out of time, we will return an answer to you via email over the next few days. So if you would like to ask a live question, you are more than encouraged to do that. You'll notice in your GoToWebinar control panel, you should see an icon that looks like a hand. And all of us should be quite familiar with the raised hand icon by this time. If you click on that, I will be able to see that you have a question that you want to ask live. I will then unmute you and ask you to go ahead and ask your question, and either Jackie, Sean, or John will provide your answer. So at this point, we do have a few questions that have been submitted in writing in the questions window. So I'm just going to go through and read these, and after each question, I will throw it back to you all to answer. So the first question, for the Part D prescription drug plan, will retirees be forced to use home delivery for regular monthly maintenance medications, or can they go and continue to go to pick up their medication at their local pharmacy monthly?
I will take that. And while we certainly think it's advantageous for retirees to use mail order, it is not a requirement. We will not force you to use mail order for that kind of medication. It's not in order to make it about me, but I'm a member, believe it or not, of United Healthcare. So I do get to use some of our or a lot of our features, like I said, with virtual visits earlier. And I'll tell you, we have maintenance medications in my household, some of which we do choose to do via mail order, but some of which we choose to pick up like we used to do. And it's up to the individual. I will say mail order does work very well for us. But again, there are some things for us, it's an individual choice that work a little bit better if we go into our pharmacy and pick them up. And you would have that exact same choice on this plan.
Thank you, Sean. Next question. Our diocese still pays the premium for the upgrade to Plus or Premium for our grandfathered retirees. And while we may not be able to give an exact chart at this point, but could you have a cost comparison for budgeting purposes? Would that something like that be available?
I'll take that one, Bob. So, you know, if you need help with that, reach out to your IBANS rep and we can help work through that. But until that chart, it's if you're paying for the premium plan today, so if I someone look at the comprehensive plan and you're paying the difference, which now I think is $205 a month to pay for that. Now that we're setting the subsidy at the premium plan, there's technically no cost to the retiree for that, the more valuable plan. So you should rethink whether or not you really need to have that additional subsidy anymore, because now the most expensive plan is being funded by CPF through the subsidy for the clergy. So consider that, look at that. So know if you look at the chart, which we showed earlier, you can do the math yourself, but if you need some help with the comparison, we can help you with that through your IBAN rep. I know some of the dioceses do provide that sort of additional subsidy to their retired clergy.
And if your institution has an IBAMS account representative, you can find out who that person is by going to cpg.org/IBAMS, IBAMS, and then you'll get the contact information for your account rep.
Mm-hmm.
Thank you, John. This question, does Medicare cover U.S. territories like Puerto Rico, Guam, and so forth?
It does, and I spoke earlier about coast to coast and did leave out Guam and Puerto Rico and U.S. territories, but Medicare, yes, this Medicare works there as well as this
plan. There's a question, when will the slides be available? Judith, they're available right now. You can download them from the handouts window in the GoToWebinar control panel. They will be available in ARC within the next few days. We have a question about repeating the website address. Jackie, the website address for admins. It's going to be cpg.org/AEAdmin. So that's AEADMIN. And that would be the new website for annual enrollment administrators. All right, let's see. We have a few more questions. A question about the Kaiser Permanente plan. Will Silver Sneakers still be involved in a part of the Kaiser plan?
It will not be off. I believe today they're not actually enrolled in the Silver Sneakers plan. I'll double check on that, but that's not, Silver Sneakers no longer be offered through our plan. So if they're with Kaiser and if Silver Sneakers is there, they're not going to have it going forward. So that would be a takeaway for them. I highly encourage the Kaiser members to really look at the new plan. It has got better benefits than the Kaiser plans have today, and we're duplicating the current Kaiser plans. We're not changing them. So the Silver Sneakers plan would not be offered to them if they have it today. I don't think it's actually getting it, but I'll double check.
Okay. Next question. This seems pretty straightforward for clergy retirees. How will this be communicated to lay retirees?
So if a lay retiree is in the plan today, they will be included in the mailing today. If they're not in a plan today, they will not be included in the mailing, but we encourage them, the administrators, to actually talk to their lay retirees who are not on our plan, and they can still enroll in the plan and reach out to us.
Okay. Well, let's see. We have a question. This is someone who's downloaded the PDF already. Page 6 of the presentation refers to both clergy and lay eligibility. Then the later subsidy illustration refers to clergy. Are lay retirees meeting the eligibility requirements on page 6 eligibility for the program and the subsidies described? So the difference between the lay and the clergy.
Yeah, so there's two different. The eligibility means you're allowed to enroll in the plan, but the subsidy is only for the clergy, the clergy, and it's all tied to the clergy pension plan. At 10 years of service, they start earning a subsidy towards the retiree health care. But lay individuals, they don't get a subsidy from the pension plan. Some dioceses may subsidize it, but from CPG, it's not subsidized. However, just the key thing is the costs have gone down dramatically. It is now more attractive for lay employees now, to purchase the plan, basically cut in half.
Thank you, John. If a retiree opts out this year, can they re-enroll another year?
Yes, they can.
How would they find out about that? Do we know?
If they opt out in 2021,
Well, there was a question asked earlier if someone is not enrolled in any of our retiree plans, but they're a retiree of an organization that provided pension and that sort of thing. Do we provide a means of contacting those who, like retirees, for example, that are not currently in our plan, to contact them to see if they want to enroll?
it's not part of the initial plan because they opted out, but we'll have to think about if do we outreach to them. The ones that are currently clients of a pension benefit, they're easy to reach. It's the ones which we have no contact with that would be harder to reach. So we've been thinking through that. But if you do have individuals who you talk to who are not in our plan, you may want to educate them on this to reach out to us.
Thank you, John. I do not see any additional questions. I don't see any hands raised. Let's wait just a moment to see if anyone has an additional question. We do have one. So the question again, Jackie, for the new administrator, you will be getting a notice. Those of you who are annual enrollment administrators for the new administrator website, that email will be coming shortly. But if you go to cpg.org/AEadmin, that's AEADMIN, that should take you to the new website. They're still working on it. All the information isn't quite there yet, but you can see what is there and what will be there. We do have a comment about what I just asked you, John, in terms of contacts. And the comment was that the chaplains to the retired are often a good resource for contacting those retirees. So that's good. Thank you.
And we are educating the chaplains of all the plans. So they're part of our socialization. So we've actually already been in contact with them, educating them about the plan, and they'll be educated all through this whole process. So they'll be a good resource for retirees.
And there is a webinar that's similar to this webinar on Thursday for the chaplains to the retirees. Any additional questions? I see no raised hands. We are approaching the end time of our webinar. All right, well, let's go on then. Those of you, when you leave, and if you've taken if you've attended our webinars in the past, you know that we have a very short survey for you at the end. So if you would please give us your information. It's just 4 questions. We actually do listen, and we do change the way we do our webinars as a result. So I would like to say thank you again to Sean, to John, and to Jackie for your presentation. Most importantly, I would like to thank all of you who have given us some of your very important and precious time to attend this webinar. We hope that it was beneficial to you. Check in ARC on the webinar page for this recording, and for a PDF of the presentation in the next few days. Thank you all again. We hope you have a wonderful rest of the summer. And this concludes today's webinar.
Thank you, Sean, Jackie, and Bob. Thank you.
Thank you so much, everybody.
Thank you.
Take care, everybody.
Bye.
Thank you.